I would say there's quite a few of you out there who know me very well, going on about my PhD all the blinking time. And the bit that I presented on the most is how midwives have facilitated out of guidelines normal physiological birth choices. And that was a huge wide range spectrum, from a little nudge out of guidelines to a giant leap where women have had multiple complexities, etc. And that knowledge is really important because it's been generated from the ground up. It's from the midwives. And this is how we can learn how the rest of us can deliver safe and personalised care. And particularly, and most importantly, this personalised care is absolutely aligned with the human rights framework. And we know personalised care is now a key policy driver. And although it's been part of everything since changing childbirth, personalised care is the buzzword, and it is being implemented across the country. So this research really helps capture and helps push forward that drive to personalised care when we understand how midwives can support those with more complex births, or just simply where they're outside the guidelines. Isn't always that complex. But tonight I wanted to shift the focus, and I wanted to share with you some insights from the PhD of what it is like for midwives actually delivering the care of out of guidelines normal physiological births. And the findings, remember, I had 45 midwives in the study, and the findings were extremely polarised, from very negative to very positive experiences within their workplaces. And that's something to be really clear about. It was their work environments that mediated how they felt and how they experienced delivering this care. And this is important because how the midwives' workplace environments are mediated in turn reinforces the ICM's concept that midwives need enabling work environments to practice to the fullest extent of their scope of practice. So we need to learn about these work environments so we can obviously, move on from those negative environments and look at the ones that are doing really well and see if we can, implement that across the board. So here's a recorded presentation for you all to watch, and I'm going to be around to take questions, so just stick them in the chat whenever you want, and we'll answer them at the end. Thank you.
Hello, my name's Dr. Claire Feeley, and I'm delighted to share this second phase of my PhD study, which explores the stories of distress versus fulfilment with narrative inquiry of midwives' experience of supporting women to alternative birthing choices. Big thanks to my professors Jill Thompson and Sue Down for all their support during my PhD. But just to unpack what I mean by alternative physiological birth choices, those are choices that go outside of maternity guidelines, where women are seeking less medical care or interventions, or when women decline recommended treatment or care. But that is really specifically for those seeking a normal birth. So this does include women and birthing people who are wanting more interventions, more medical care. Not that they're not important, but it wasn't the focus of my PhD. And we know that supporting women's choice matters for so many reasons. It has a long-term biopsychosocial impact if they don't feel supported in their choices. And that's all linked to issues around control, bodily autonomy, providing dignified and respectful care. Which we know makes a difference between a positive and a negative birth experience. Even where women's birth desires don't go according to plan, even when emergencies arise, the international literature very much telling us the mitigating factor between a stressful or frightening experience and one that would lead to really negative experience and PTSD is the care that they were given. Were they fully supported? Did they feel safe? Were they still central to the decision making around that emergency care? And we know that has a huge impact across the woman's life course. And all of this is connected to human rights. So although some practitioners are less comfortable with out of guidelines birth choices, particularly where they deem women to have risk factors that preclude them from perhaps having their home birth or birthing on the birth centre, we need to move beyond that, because of all of these things here in this slide are so important for women and their experiences, and that long-term effect. So while in the UK we have got the best legislation in the world in terms of human rights during childbirth, we have got some of the best policy, we've got some of the best infrastructure in terms of, because we have the NHS, home births generally in birth centres, we've got that infrastructure between primary and secondary. Hello, my name is Dr. Claire Feeley and I'm delighted to share the second phase of my PhD study, which explores the stories of distress versus fulfillment, which is a narrative inquiry of midwives' experience of supporting women's alternative birthing choices. Big thanks to my professors Jill Thompson and Sue Down for all their support during my PhD. But just to unpack what I mean by alternative physiological birth choices, those are choices that go outside of maternity guidelines, where women are seeking less medical care or interventions, or when women decline recommended treatment or care. But that is really specifically for those seeking a normal birth. So this does preclude women and birthing people who are wanting more interventions, more medical care. Not that they're not important, but it wasn't the focus of my PhD. And we know that supporting women's choice matters for so many reasons, and it has a long-term biopsychosocial impact if they don't feel supported in their choices. And that's all linked to issues around control, bodily autonomy, providing dignified and respectful care, which we know makes a difference between a positive and a negative birth experience. Even where women's birth desires don't go according to plan, even when emergencies arise, the international literature is very much telling us the mitigating factor between a stressful or a frightening experience and one that would lead to really negative experience and PTSD is the care that they were given. Were they fully supported? Did they feel safe? Were they still central to the decision making around that emergency care? And we know that has a huge impact across the woman's life course. And all of this is connected to human rights. So although some practitioners are less comfortable with out of guidelines birth choices, particularly where they deem women to have risk factors that preclude them from perhaps having the home birth or birthing on the birth centre, we need to move beyond that, because of all of these things here in this slide are so important for women and their experiences and that long-term effect. So while in the UK we have got the best legislation in the world in terms of human rights during childbirth, we have got some of the best policy, we've got some of the best infrastructure in terms of, because we have the NHS, home births generally in birth centres, we've got that infrastructure between primary and secondary care, community care, and then hospital care. So we do have some really positive things within the UK. However, we cannot be divorced from this cultural web of context, where although all the policy documents, the legislation even, absolutely is underpinned by choice and bodily autonomy, however, there's issues around that being rhetorical versus the reality. So very often women may not feel that they are able to assert their agency and retain that bodily autonomy. And the reasons for this are extraordinarily complex, which is why I like to use the web analogy. We've got issues around the wider discourses of growing medicalisation, institutionalisation. So that's when you look at the hospital-based care, and when you look at that from a population level, we do a bloody good job. However, because of the scale, because of the size, the busyness, it lends itself to routines, and these routines can get entrenched. And then that is also in turn something that is coined as routine-based care, as opposed to individuals getting their needs met. Particularly maternity care, particularly in that birthing sphere, birth does not perform under these strict time measures, and it does not conform to routines. However, that's where the issues come in, when you've got this clash of institutionalisation. And then, of course, we can't get away from the risk and litigious society, the broader society we're in, but it's particularly acute within maternity care. And issues around governance also linked to institutionalisation, and I'll have to come back to that another time. The other thing to bear in mind in terms of thinking about context is that midwives are not a homogenous group, unsurprising to the audience here. However, although the title of a midwife is legally protected, it's internationally defined, and there are key aspects which make up a midwifery philosophy of care. That's not to say that all midwives align with that philosophy of care. So some midwives are much more comfortable within this institutionalized, medicalized framework of delivering childbearing care, and then others do not. Others really wish to what we call have a woman-centered approach, where that individual, their needs are absolutely paramount and supersede the larger scale institution. And obviously things like that are very dependent on midwives' personal experiences, professional experiences. Perhaps they've had a bad outcome. They might have had their own experiences of birthing care themselves when they've had their own babies, etc. So it's just really important to think about the complexities around the issues. So for my study, I interviewed and gathered narratives, self-written narratives from 45 NHS midwives from across the UK. Very important to capture those from different practice settings, like I mentioned earlier, community, the hospital, different places within the hospital, those who deliver home birth care, those who work in birth centres. And it was very important, and I'm very pleased that different midwives with different levels of experience. So from very junior, just newly qualified, which is the band 5 you can see here, to very senior, perhaps consultant midwives, very experienced. But what I sought out to do was actually ask the data 3 research questions. So you can see it's a narrative inquiry, but it's a pluralist analysis. So previous work which has been published was really looking at the nuts and bolts of that midwifery care. How did they do it? Today, I'm going to focus on their experiences of facilitating, bearing in mind that cultural web of context I've already described, that I suppose you're starting to get the idea that this might not be straightforward, even though we've got this amazing legislation, infrastructure and policy. And then leading on from today is another analysis, and that is looking and using what we know from these first 2 levels of analysis. And then I put that into a theoretical model to explain the social, cultural, political influences on the midwives' care. So in this part of the study, where it's really around meaning-making, sense-making for the midwives, after they told me very detailed, in-depth and a wide variety of stories, professional stories of where they've been involved with looking after women out of guidelines. These range from just what we'd call a nudge outside of guidelines, nothing spectacularly complicated, to really complex cases where women had multiple medical and obstetric needs, and perhaps they were seeking a home birth. But moving away from those specific stories or examples of the practice, the reason why I wanted so many people in the study was to look beyond the specifics and get to a bigger sense, a broader sense. So for these midwives, they self-defined as facilitative of women's choices. So that means that this is part of their normal practice. And you can see from these storyline themes here that we've got quite a polarization. Stories of distress all the way down to stories of fulfillment. The most important, I suppose, take-home message within just 15 minutes to talk about this today is that the work environment was the mediating factor between these really distressing stories up at the top here and these stories of fulfillment. Issues around lack of support within their immediate work environment, so their immediate teams, place of work, and then the broader hospital, trust, guidelines, etc. Top down, bottom up, that was either super unsupportive or incredibly supportive. So we've got issues around whether midwives obstructed in delivering the care that they wanted to, in supporting and fulfilling their duties. Midwives we are regulated, we have to assign, we are registered. So there are certain things within our professional code of conduct we have to do, but sometimes that there's a tension between that and what our employers want us to do. So we've got issues here around whether midwives obstructed to deliver the care or were they enabled. And this also very much married to their philosophy. Did their philosophy, the personal philosophy of these midwives, perhaps there was either an alignment with their wider teams and the institutional norms, or a radical misalignment, as you will see just shortly. So here we've got Meg. Her feelings have been torn, permeated across her interview through several examples, all of which related to Meg's concern that the relevant hospital guidelines were not based on good evidence and were detrimental to women's experience of care. So she was torn between her personal knowledge, her professional knowledge, and her employer expectations of working within the guidelines. So she expressed deep moral conflict. And you can see here, and there's one example, but basically I've been in a theatre with this woman, holding her hands as things were happening, and I just thought, this shouldn't be happening. And I feel that was a terrible moral dilemma. It feels deeply immoral to me. Yes, I feel it's a real dilemma. And then she moves on, and you can see in this next quote, what I feel to be right is conflicted to what my employer is expecting of me. That's difficult to live with. Yeah, I sometimes feel I've acted immoral. I feel powerless. I don't feel agency within the situation. And unique, maybe not unique to Meg, but it was very stark that she internalized that. She blamed herself rather than expressing anger towards the institution, which some of the other counts were much more vocally angry with the position they felt they were put in. So just to give you a little brief insight to what I meant by battle, here's a little quote that was kindly recorded from a colleague of mine.
I often feel like I'm labelled as a troublemaker midwife when I walk on the labour ward, that people think I'm brainwashing my women to decline induction or decline prophylactic antibiotics, etc., when in reality I'm just supporting them to make their own informed decisions. Once women realise that they have a choice and a voice, they feel more confident to do what feels right for them in their own unique circumstances.
And in the more extreme reproach and recrimination, they had midwives who were referred to the NMC, their statutory body. They were under investigation. And you can hear the pain in this next and the conflicts around the situation, as this midwife felt very much pressured by her seniors that she didn't coerce the woman strongly enough in having a vaginal examination.
My colleagues and supervisor of midwives have advised me that I should be more forceful or get another midwife into the room to help me convince the woman. But I strongly believe that consent's a choice. You know, if you thoroughly explain what you want to do and the rationale behind why you want to do it, if the woman does not want you to do whatever it is you're wanting to do, you don't do it. Otherwise, it's not consent, is it? And that could be classed as abuse.
So we've got this, what feels like very straightforward legislation in this country to protect women from coercive practices, abusive practices, because putting your hands on a woman where she's not consented is against the law. But you can see these conflicts as they intermix and relate to that cultural web, complex web, contextual web for the midwives. And you can perhaps hear and indicate the fear from the senior midwives by not doing what's expected of them from an employee perspective. However, in deep contrast were the midwives with stories of fulfillment, and these related to a sense of the ordinary, where the midwifery practices were marked by a lack of conflict, animosity, or distress. So rather a feeling, rather a feeling of being able to get on with the job, they were able to facilitate women's and birthing people's choices. And this was generally associated with midwives being situated within supportive working environments where women's alternative choices were mostly accepted. And so for some of them, the narratives related to a sense of camaraderie, either between themselves or the women or themselves and the team. And then a few participants expressed a feeling of the sublime through accounts of love or tenderness, attunement and reverence. So the key message, midwives had reported extremely polarised experiences, and this was mediated by social and cultural contexts. Their ability to practice woman or person-centred care was strongly influenced by their working environments. Organisational cultures, so you've got blame and punitive versus supportive and enabling, were the key mediating factors between positive and negative experiences. For those experiencing negativity, it raises concerns about sustainability, where you've got this great distress, stress, and impact on mental and physical health. How can those midwives continue to serve the women in the way they have been, whilst continuing in an unsupported environment? Positive organisational cultures were also identified. So where midwives and women's autonomy were respected and supported, it does show the feasibility and achievability of delivering this sort of care within large-scale organisations. I'm really mindful that's a whistle-stop tour through very rich findings. I'm hoping that you will come find me at my website if you want to learn more. Thank you so much.
Okay, Claire, did you want to add anything to your presentation at that point?
Sorry, I wasn't sure you were waiting for me. Yeah, as I pre-recorded that for a conference a while back, I realised watching it back there, I didn't press play on one of the most beautiful quotes. So if I can find that separately, I'll play it at the end. I see that I must have been running out of time for it and skipped to the next slide. But no, hopefully that's a snapshot. And this is the paper that was published. So if you want more insights and more of a really either heartbreaking or beautiful quotes, it's the one called Stories of Distress versus Fulfillment. And you can message me for a PDF if you can't access it, but I would have thought a fair amount of the audience have access to Athens, and you can get that from the Women and Birth Journal. But, you know, get in touch with me, it's absolutely fine. But it really is worth taking the time to read just the extraordinary polarization. But how great. We've got midwives working in amazing environments, and they could just get on with it and then have these amazing, beautiful, really highly connective, reciprocal experiences, which changed some of the midwives' lives forever because they had such beautiful connections with the people in their care. So I'll probably leave it there.